I'm especially privileged today to introduce Adam Goldstein to the group. I think most of you know Adam probably very well. He's professor of family medicine and director of the UNC Tobacco Prevention and Evaluation Program, and there's some other titles on this slide also. Adam joined the UNC faculty in family medicine in 1993 as a clinical assistant professor, and since then I think it's fair to say that his career has evolved to a greater focus in research scholarship after completing research-based fellowships in primary care and preventive medicine and then getting his NPH in 2003. From the very beginning, his scholarship has focused on substance addiction, particularly that related to tobacco. And as most of you know, I'm sure he's a nationally respected expert in tobacco, nicotine addiction, and prevention, having given multiple talks nationally on this topic and published widely. He has been a staunch advocate for other community prevention programs, including immunizations, blood pressure control, etc. He's especially committed to community service, to medical activism, and healthcare policy development, and is really a role model for our trainees in the institution in these areas. I didn't realize until today that he's also an author of a dermatology textbook along with his wife Beth. I had totally missed that, and it's apparently one of the best-selling textbooks in dermatology. And today you can see the title of his talk, Emerging Concepts in Tobacco Cessation and Nicotine Addiction. I think it's a very timely topic for all of us as we have an institution that's just gone smoke-free. Thanks, Adam.
Thank you very much. I appreciate it. It's fun to actually be here because there's been a lot that has really changed over the last year. I think I might have done a grand rounds on tobacco and medicine 8 to 10 years ago maybe. And at the time, it was probably a half-empty talk. And today, you could also give this talk half full because of really all the changes and positive things that are happening. So it's an exciting time. Not only for the institution, but for those who are doing research in this field, those who are hoping to see benefits for their patients, and really for all clinicians, because there are now new tools, new drugs, new policies that are in place that really help prevent at least 1 out of 4, if not 1 out of 3 patients that get admitted to our hospital having tobacco-related illnesses, and 1 out of 4 probably patients in the outpatient setting that are there in some way or fashion. What I hope that we can do in the next 50 minutes is I want to review new current evidence-based guidelines. For those of you who got your clinical evidence BMJ publication yesterday and you saw Smoking Cessation 2007, no, I haven't read that whole thing, so if you've read it all and you have a question about it, you will have to give the answer as well. But we will cover it right up until yesterday. We're going to talk about some of the skills about brief counseling strategies. A lot of these will apply to some other health behaviors, but these are specific for tobacco. We're going to talk about the 7 pharmacotherapies that are FDA approved. We'll also talk briefly about coding, though really that's a very complex area that requires actually much more sophistication, but we'll talk briefly about it. And then we'll finish up looking at policies at UNC as well as policies around the state that are appropriate. For those of you who are really interested in this issue, Dr. Alan Brandt also is going to be, who was formerly a research scholar here at UNC, now professor of social medicine, I think up at Harvard, will be here on Monday delivering, I don't know if it's the Merriman lecture at 12 noon. And we recently read a book about the history, the rise, fall, and the resurgence of the tobacco industry. So it should be really interesting, and I encourage you to go. This is not a talk about the risk factors for smoking as a disease, because you know about the cardiovascular, the myriad of cancer, the myriad of respiratory and reproductive, and then the myriad of other things. So we certainly don't have to go into those things. You're also aware of the substantial overall morbidity mortality, and we only repeat it just to continue to remind us, because we get desensitized to this when we remember that it's almost 1 out of 5 deaths, 1 out of 5 deaths in North Carolina, preventable deaths 37%, 435,000 total deaths a year in the United States. Smoking-related mortality, 40% of neoplasms. That's really the extent of epidemiology. One more about secondhand smoke, to remind ourselves that up to 36,000 deaths a year in the United States are due to secondhand smoke exposure. So when we're talking about policies at UNC or UNC campus policy or UNC hospital policy to essentially eliminate secondhand smoke exposure or to drastically reduce it here on this campus, these are substantive issues that are based upon sound public policy, sound health. And it's a little dismaying if you pick up the News and Observer today and you read in the Metro section a column written that phrases it as, how do you feel about the smokers' rights being limited at UNC? It really should be, how do you feel about being exposed to over 40 cancer-causing agents involuntarily at UNC? That's how the debate should be framed, and unfortunately, it's still not quite gotten there. I'll just mention about cigars, because we always think about cigarettes and smokeless tobacco. But remember, cigars are not benign with the tar, carbon monoxide, nicotine, elevated risk of particularly lip and esophageal cancer. Alternative cigarettes, BDs, the hookahs that are in Chapel Hill and around the country. Again, these are not benign, even though they are pitched that way. Remember that it's the tobacco that is the carcinogen and nicotine is the addiction. And to separate those things out, because when we talk about a lot of the pharmacotherapies, and like we were talking with the patient in our nicotine dependence clinic this morning, I'm not really particularly concerned if you're on nicotine for years and years and years. I am concerned if you're on tobacco for years and years and years. And so that differentiation is oftentimes very helpful. Remember, smoking is an infectious disease. And what is the cause of the infectious disease? Just as a little segue, if you go to Dr. Brandt's talk on Monday, remember that you get it from tobacco companies. And so I think it's quite important to continue to remember this talk is not about the marketing, but I will just to give you a little tidbit here to think about that the marketing on the product to get people to use it is over 50% of the NIH budget of annual spending to promote it. This is targeted to youth, increasingly to young adults, 18 to 25, through a whole variety of elements there. And this is just one thing, because we did some research published in JAMA 5-6 years ago that showed that 2/3 of all movies, even marketed to G-rated movies, had depictions of tobacco and alcohol in them. And this was a nice study by DeFranz and Sargent and a lot of research they've done showing a dose-response relationship between the amount of exposure to tobacco use in movies, which traditionally was paid product placement, and consumption among youth. And this tends to be one of the greater risk factors among experimentation among youth. So again, most of this talk is really not about primary prevention or social inoculation. We talked about that a lot with the pediatrics, but it is about secondary prevention and cessation. To remind ourselves about cessation and the benefits of it, because we sometimes, again, get immune to think, well, what does it really matter if they've been smoking 20, 30, 40 years? There's a continuum of benefits ranging from at 1 year reducing our heart mortality by 50% to 10 years out that the lung cancer risk going down to almost 50%. So the longer you go out, the more benefit. You really never get all of your lung cancer risk down. You do get almost all of your cardiovascular risk down. And within hours, you actually start seeing changes that are important in terms of cardiovascular risk and coronary spasm. And we can also show exposure to secondhand smoke. Within hours, conversely, you can see changes on ultrasound and echocardiogram of decreased blood flow. They actually did this among Japanese medical students. Don't know if it passed our IRB. If Dr. Bernard is here, I'm sure it wouldn't. If we look at when you quit, again, you see benefits. So the lower line are the cigarette smokers and the percent survival, and the upper line are the non-smokers, and we see that those who stop between ages of 35 and 44 ultimately begin to approach the non-smokers over time, and their trajectory looks more like them. Even if you quit at age 50, your benefits are stronger. They're not quite as strong, but they're, again, significant. So again, cessation has benefits at virtually all ages, and there was actually a Surgeon General's report on cessation that looked at this at every age along the continuum there. Conversely, there's a dose-response relation. The more you smoke, the more the harm is, but there's very little evidence that just cutting down on smoking actually has any benefit. So if a patient says they go from 20 to 10 cigarettes, that is not necessarily a benefit. Matter of fact, it could be disadvantageous to them because they tend to have compensatory changes like smoking that cigarette longer, to more toward the nub, inhaling deeper, covering the filter pores, so they actually upregulate to try to get more nicotine, and they get more potentially carcinogens. So very interesting about just cutting down, and it's not a recommended evidence-based strategy. There are 8 evidence-based strategies. First off, it's chronic. So if someone relapses after a year, like someone we saw in our nicotine-dependent clinic today, that's expected. It's a chronic. It's like high blood pressure. You may have it controlled for 10 years, but then it becomes out of control. So we think about it like this. We don't think about the patient. They've quit for 2 years. I don't have to think about them again. They do need to ask about it when they come back into the clinic because of being a chronic conditions, repeated intervention. Since there are lots of effective treatments, everyone should be offered at least one of the treatments. We don't think about this as either it's effective or not effective. There are multiple ways of treating and supporting patients. Thirdly, if we institutionalize it, and this is no surprise to us, we do better. And I'll show you some data of what we've actually done here at UNC and the impact we've had by that. Brief treatment is effective. So if you're counseling patients for 3 minutes in your clinic, that is effective. Turns out if you counsel them for 10 minutes, it's more effective. So that's why we begin to have things like specialty clinics. You have a pharmacist here up in medicine who counsel patients. And again, but brief treatment is effective. Is a dose-response relationship that I just mentioned there between counseling and effectiveness, and then knowing which types of treatments are effective so that you don't focus on things that are ineffective. So social support within the treatment setting, having multiple people that can support the patient, like the therapist, like the pharmacist, like the physician, like the nurse, like the checkout person. Support outside of treatment, family members, and ways of building support into that recommendation for counseling. And then specifically skills training, problem solving. We'll come back to and perhaps talk about what you can do, because in 3 minutes, you can focus on a quit date, you can focus on skills problem training, and you can focus on follow-up. And you can do that in 3 minutes, and potentially a prescription. Again, numerous effective pharmacotherapies exist, so everyone should be offered it in the absence. However, we know that 20 or 30% of patients can quit on their own successfully. So it's not, and in the new recommendations, we'll probably see that will be one of the recommendations in addition to pharmacotherapies. They're clinically effective and cost-effective, and I think I've got one slide on that. Just to give you some sense there, the attributable effect of us counseling on adults is 7 to 14%. I'm not going to really talk about the pediatrics today. If you think about what the clinical evidence guidelines talk to us about, they talk to us about things that we can do to improve cessation, and they also talk to us about things that we can do in the community. I'm going to touch on the things in the community, though I won't spend much time on them, but they do include things like raising the price of the tobacco products, mass media campaigns, and then legislation there. In terms of the public health practice, what they recommend, of course, are 5 A's, and all of us seem to have a hard time remembering if it's ask, advise, assess, assist, arrange, or advise, ask. Getting them in the right order seems to be a problem, but it's a mnemonic for helping us to remember that there are steps that we have to do. If you don't ask about tobacco use, there's no way that you can assist the patient or advise them to quit. And so one of the biggest problems we've had in this institution, as well as institutions around the country, is that we routinely don't ask patients if they use tobacco. We miss a lot of patients there, and we've done things to help us out that, and I'll show you that in a second. Of course, if we tend to ask it, we do tend to advise, and this is something that we do pretty well if, we've asked them there. And this is where we will spend a few minutes talking about motivational interviewing, assessing whether or not they're ready to quit, because if they're not ready to quit, we really shouldn't spend much time. It's pretty much a waste of time, other than perhaps trying to find out why they don't want to quit in light of the information that they know, and then helping them with a quit date, and then some strategies for quitting there. There will be a follow-up visit, and there's data. If you have follow-up visits, then actually the patients do better there. And those indeed are the 5 A's. And again, there are elements for pediatric practices that are not particularly have to do for today. The implication is that if we do this counseling for all patients, that we will have have a significantly less smokers each and every year, and that's actually an important consideration here. We'll throw a few humorous things in every now and then. Remember again that the tobacco is carcinogenic and the nicotine is addictive there. And the nicotine receptors, it's important to realize that we now know that these alpha-4 beta-2 receptors up in the CNS, and that nicotine binds to these receptors, releasing dopamine, which leads to a reward basis. And this also means that as the nicotine is depleted from the receptor, that reward basis tends to go away, and that leads to people wanting to smoke again and get tobacco again, and then also that leads to continued regulation of the receptors, so you actually have to smoke sometimes more, and the receptors don't work as efficiently as with many other elements. And without that, then there is tolerance and issues with addiction there. In terms of the guidelines, we've covered some of these elements with when these things occur. Things that we can do within the treatment setting in terms of in the clinic there, the support that we can do as physicians and other people in the clinic is, again, encouraging patients with supportive statements in terms of their belief that they can be effective, trying to raise their self-efficacy. The things outside of treatment, trying to get the spouse, their friends, their coworkers involved in supporting them. And then again, in terms of the skill problem, or the third thing in terms of cessation are, what are the things that you can do when you want to quit instead of smoking? Because if you say I tell most of you, you're going on a trip tomorrow, good luck, and you all of a sudden leave, you would leave lots of important things that you wouldn't think about. Well, we're telling people to quit smoking within a day or two, and then they have an urge to smoke, and they're smoking 20 times a day. There are 20 different urges, and it's not just the nicotine, it's a lot of the behavioral aspects of the urges. When are they smoking? After drinking, or after driving, or after a meal? And so you have to have lots of things to do. So we work on, in our specialty clinic, working with them to come up with things that they can do, 20 things that they can do that really take their mind off of. Some of them have to do with more with meditation, like taking a deep breath. Some of them have to do with satiation, like drinking a glass of water. Some of them have to do with behavioral aspects, like chewing gum or a toothpick. Some of them have to do with some exercise to have some more positive benefits, walking. Some of them are the social support, like hugs. Some of them are doing things with their hands. So again, a variety of things that hit the different types of impulses for folks there. In terms of the cost effectiveness, again, if you think about smoking cessation compared to things like mammography and high cholesterol, incredibly cost effective. Behavioral counseling and medication are better than either alone, and this shows that with medication, with therapy, that 30% compared to behavioral medication alone without therapy, or just the medication without therapy of 10%. So again, we really want to work at both of those. Sometimes we can take 2 A's instead of 5 A's and just think about ask and assess and then do something. So again, if you want to just modify, this is from the American Academy of Family Physicians, it can be more useful. The Joint Commission actually says that we have to do tobacco education counseling. 2 of the 4 measures, so folks who are admitted to the hospital with heart failure, heart infections, pneumonia, and or pregnancy, demonstrating that they have some counseling and must be documented, and now there are nurses here at the hospital that are going around checking charts, and if these things aren't being done, they're actually doing it on the spot because we risk losing money. If you look at your CIS, and I assume yours is like ours in family practice, back in February of 2007, smoking was not a vital sign. And so there has been data in JAMA and other publications that if you make it into a vital sign, people, obviously they know about the asking of the tobacco because it's right there in front of them, and that this should be, because it's probably more important in most cases than respiratory, it's probably most important in most cases than height, and yet those are vital signs. So we were able, through help of the leadership of the system, to get smoking as a vital sign. And so it's now there, current smoker there, which means that for the most part, it's getting asked a lot more than it was in the past. And of course, it's not just getting asked, there's a second question there that if they are a current smoker, do they plan on quitting? So the ask and the assess are now right there for us. And there is data that we have from doing chart reviews of 400 patients before this went into effect and only 1 month after this went into effect, that there's a substantial increase in the identification of tobacco-using patients in our healthcare system. And those patients that we've now identified, there's a substantial, significant increase in counseling that's occurring and it's only on those that are actually being assessed. If they're only being asked and not assessed, there's very little counseling that's being occurring there. And yet there's still 25% of patients that we can document are tobacco users that still aren't getting asked, even though it's a vital sign. So we still have a ways to go. Looking at internal medicine compared to medicine, family practice, pediatrics, and psychiatry, you all are doing the best, actually. And I think it has to do for a lot of different reasons. All clinic, family medicine and internal medicine both had increases. Psychiatry is doing the worst right now. We're doing some grand rounds of psychiatry because it's really very, very, very low there. So 1 minute about their willingness to quit in the next 30 days. They want to quit, you can help them. They don't want to quit, then you can think about why. Because the real question is, why don't they want to quit? So you have a patient that smokes, they want to quit. What's the first question you should ask that patient? Do you want to quit smoking the next 30 days? Because if they don't, again, you're going to be wasting time with them probably there. And if they don't, we'll do about a motivational interview. And if they do, you can help them. So motivational interviewing is just taking 30 seconds to a minute or two and trying to figure out with the patient why. It's not about me talking to them and telling them what to do. You know, if you don't quit smoking, you're going to die. That's not motivational interviewing. That actually causes people to want to smoke more. So it's saying, I know this is difficult. Help me understand why. In light of what you know, why don't you want to? What do you enjoy about it? I enjoy it. What do you enjoy? And beginning to understand, what would it take to want to get you to quit smoking? I would want to quit when my daughter's born. When's your daughter born? Oh, my wife's pregnant. Okay, you have something in mind. You have a frame in there that gets them there. I would quit smoking if I knew it was damaging to my health. You have a frame to motivate them there. So again, I'm not an expert lecturing to them. I'm not arguing with them. I'm not giving them their solutions. And I'm listening there. And then there's all kinds of frames, questions that one can ask to be motivational there. Get permission to have a conversation with them in the future. Is it okay to ask you to consider quitting in the future? And again, I'm here when you're ready to do that. And again, that's how you end it in terms of the motivational aspects. Frozen, Bill. Okay. Again, the motivation along with the advice to quit there, and then assisting them with a quit plan. And a quit plan is nothing more than getting them a quit date, 2 days to 2 weeks. If it's more than 2 weeks, it's too long, they don't remember it. If it's less than 2 days, it's probably too soon to really figure it out. This is one of the few times I actually still use the prescriptions to write out the quit date because I can make a copy for them and give it to them. And it has the power of the prescription behind it there. And then I can help them begin to think about the things they're going to do, the problem-solving skills. I can write out 5 or 10 of those things and then get them to write out the others. And then think about the pharmacology there and then a follow-up appointment there. And you can go through and follow up whether or not they've relapsed, how to recommit, how they can learn, and if they haven't relapsed, again, they're still at risk for the next time. So typically in our clinic, we'll follow them at 2 weeks, at a month, at 2 months, 3 months. We'll follow them 4 or 5 times there. And just to summarize, little contact versus no contact, better cessation. The more the contact, the better. The more you counsel, the better. And you can send them for group counseling. Group counseling is effective, but most patients don't go for group counseling. We're running now in cooperation with occupational health classes for employees of the UNC healthcare system. But other than the first 1 or 2 classes right around the time the hospital implemented its policy, most employees aren't really going through that. They're quitting. They're going through their primary providers. They're going through our clinic and trying to get a one-on-one and getting the prescriptions elements there. You can do a nicotine dependence questionnaire to find out if they're truly nicotine dependent. My question is, have you quit smoking in the last 10 years? And what's the longest you've quit smoking? If they've gone for a year without smoking, then they can quit potentially, particularly if they did it without pharmacotherapy. But if they go for more than, if they can't go for a minute without smoking, when you have your first cigarette in the morning, is it right when you roll out of bed? The answer is when they roll out of bed, then they're not really, they're probably nicotine dependent there. So again, if they smoke more than 10 cigarettes a day, they're probably nicotine dependent. The 5 therapies, the nicotine replacement, the gum, patch, nasal spray, inhaler, and lozenge. We've worked with Howard Peckman and the pharmacy committee here so that there are now increased choices on the therapy for both inpatients and outpatients. And so the lozenge is a new one that's been added to the formulary. The inhaler is added to the formulary. And again, for most patients, a lot of them will have tried the patch and the gum when they see you. They may not have tried the nasal spray and the inhaler, which are both prescription. They may well have tried the lozenge, or they may not be aware of the lozenge. The lozenge is good because you can put it in your mouth. It's unobtrusive there. Most of these mimic milligram for milligram cigarettes. So if you smoke a cigarette, it's about 1 milligram of nicotine. You do a pack a day, that's 20 milligrams. So you're going to need about 20 milligrams, i.e. a patch is 21 milligrams frequently, the starting dose of a patch. So if it's a 2 milligram piece of gum, they may need 10 pieces of gum. There's 4 milligram pieces of gum. There's lozenges are 2 and 4 milligrams. The nasal spray and the inhaler work a little bit differently, as you know. The inhaler is more like a puffer, but you don't really, it's more, and you have to take like 20 or 40 an hour little puffs. You get little bouts of it in there. So it's good for people who want they want something to do with their hands. The nicotine and nasal inhaler is good for people because you get really rapid doses of nicotine to your brain. Problem is it goes down real quickly. It has some addictive abuse potential. Can't use it if you have sinusitis. You can't use the nicotine oral inhaler if you've got COPD. That's about all you need to know about most of the nicotine products there. And of course the pictures there. Again, this looks at the dose of the nicotine over time. The top one is the cigarette, and the nicotine of the gum comes the closest to approximating it an hour into the dosing of the 4 milligram piece of gum there. The nasal spray gets much quicker initially, but then goes down, and the patch takes time. So if you've got a patient in the hospital who's nicotine addicted, and you're going to put them on a patch, it may take hours before they actually can feel the impact, and they may need to be on a nicotine gum or nicotine lozenge in addition. We actually have new nicotine dependence order sets within the last 3 months in the hospital. So under your CPOE, you can go in and you can find nicotine dependence order sets that have comprehensive now inpatient guides to everything you probably would need to do in the hospital, including you can put in a nicotine dependence consult, because we have a consult service now. It has all of the inpatient nicotine products there that you can order. You can check off for nurse counseling. You can check off a whole bunch of things that just makes it easier for you if you have a patient that's nicotine addicted in the hospital. The meta-analyses show that most of the nicotine replacement products are about 20% in the outpatient clinical setting. They're not as good as these studies. They're probably 12 to 15% there. Bupropion is closer to 30% in the clinical trials, and then the varenicline, the new one, Chantix, is closer to 40% in the clinical trials there. So again, the lozenge is something that many of you may not have tried. It is something that probably can be used in a lot of settings, and particularly in addition to some of the other elements there. Again, very few contraindications. So there are some who had a recent MI. I got a allergy to the patch. Usually that's local there. The sustained-release bupropion, it's called Zyban. Why is it called Zyban rather than sustained-release bupropion? Because Zyban comes with a benefit, web-based, telephone-based behavioral support program. We've already mentioned that it works better with those two things. And it was approved as Zyban. FDA approved it. They didn't approve bupropion. Now, you may say that's a moot point, but it really isn't. And we'll come to a case, I think, in a minute or two about this, and you have to think about that. That we don't really know how its mechanism of action fully in terms of smoking cessation. There are lots of different side effects. You're familiar with this from using it maybe for depression or attention deficit disorder, particularly those with a seizure disorder. I have a lot of patients who taste things in their mouth and dreams, and this kind of thing, sleep disturbances in terms of its use there. But again, up until a year ago, this was really the only other first-line pharmacotherapy that we were thinking about. The varenicline or Chantix, the alpha-4 beta-2 nicotine receptors there, that actually is the first drug specifically made for smoking cessation to attack at the receptor level. It's a partial agonist, antagonist, so it fills the receptor. So if you smoke cigarettes, you don't get any reinforcing effects from it. So most patients don't smoke because there's nothing they get from it. It also avoids the withdrawal by filling the receptor there. So but yet it doesn't provide the reward mechanisms there. So again, its abuse potential is considered to be very, very low, and it does, the higher the dose, the better it is, and it's recommended BID dosing for tolerability. And these are some studies that were in JAMA that again looked at varenicline versus bupropion SR versus the placebo there, and again, 40% response rates. Of course, they go down over time there, so continuous abstinence rates from weeks 13 to 34 went down to 13 to 52 weeks, but that's not unexpected because, again, this is a chronic disorder, patients relapse, but again, and you see this across treatments there, but it also suggests that there is continued benefit. It's recommended at least 3 months, probably 6 months, but for some patients, even up to a year there. Again, that's not to be unexpected. Its main side effect is nausea. 30% of patients up to them are probably going to have it. You can reduce the dose on it. You can try it with a proton pump inhibitor, 2 different strategies there. And again, it's just like Wellbutrin, Zyban, a starting dose that increases to a stable dose there, and by the end of the first week, 1 milligram tablet twice a day. Pretty simple element. Most of these programs have behavioral support programs encouraging your patients to actually utilize them because only a minority actually use them. There are a lot of money going into them. Actually, varenicline is doing just started direct-to-consumer marketing, trying to encourage patients to go to their website to utilize these approaches there. Again, and this is a copy of one of their slides, but again, most of the programs have them. So, a patient wants to quit smoking within 30 days. You counsel about social support and problem-solving skills, and they've gotten a quit date. They've tried nicotine replacement therapy, the gum and the patch individually. What prescription would you recommend next, and what else would you do? These are not dissimilar from patients that you're going to see. Well, if they want to stay with nicotine replacement, you could consider the lozenge. If they have comorbid depression or other things, and they're not on an SSRI, or if they are, you can maybe switch, but or some sort of dysthymic or mood disorder, that might be a good indication. And varenicline would also be a good indication. You can do some combinations, though again, I think combinations are more likely to be things that we would do in our nicotine dependence clinic, or if you have more experience with that. And then you refer them to the Quitline, and we'll talk about that. If it's a hospitalized patient, if they have psychiatric comorbidity, if they use smokeless tobacco, these are all special cases for which actually there are nuances here that sometimes you may want to do some consultation. This just shows the rates of tobacco use, 20 to 25% in the general population, but for patients with psychiatric diagnoses, well over 50%, up to 80% there. I mentioned about reimbursement. In terms of Medicare covers counseling and pharmacotherapy up to 2 quit attempts a year with 4 counseling sessions there. Medicare Part D covers prescribed smoking cessation treatments there, and it's the 305.1 that tobacco dependence could discover. There are lots of other ICD-9 diagnostic codes. If you are counseling patients and they have any of these things, including cough, which is my favorite one, you can use an E&M code because it's part of the way that you can figure out the reimbursement. If you're doing some procedural codes, again, things that one might not always think about there. It can be part of potentially a preventive medicine, a tobacco dependence treatment, nurse counseling, psychiatric. If you're doing just the counseling and spending more than 30 minutes, it can be the predominant part of the billing aspect on time alone there. So again, lots of different ways of trying to wrap around the coding issue. Medicaid is physician counseling as a covered benefit now, and then the state health plan. Counseling is a covered benefit along with the prescription and over-the-counter products. The copays are waived for the over-the-counter products, a smaller copay for Zyban, a larger copay for varenicline. Quitlines, there's both reactive and proactive. Increasingly, the proactive ones, so you call 1-800-QUIT-NOW. Any patient you have can call 1-800-QUIT-NOW with or without your referral. You can refer patients by doing a fax referral, and the people will call them up, and they'll do proactive counseling and by trained counselors doing individualized, tailored approaches there. And they overcome a lot of the barriers because there's no transportation, they're convenient, they can hit folks in rural areas, you can do it in diverse languages, and you can hit vulnerable populations that are more difficult to reach there. A systematic review has shown that there's an absolute 2.6% difference in those who use this, which is a 41% relative increase. So again, this is an evidence-based approach to that. North Carolina, unfortunately, has this bad thing. They put, you don't have to go cold turkey, and they did this whole campaign around a turkey, which they're actually going back to, because our evaluation showed that was actually a bad symbol for a lot of people. But the 1-800-QUIT-NOW, we evaluate the North Carolina Quitline with our research and our tobacco evaluation program. We just released a report to the Health and Wellness Trust Fund in North Carolina. First 20 months since it's been in operation, 6,500 callers from North Carolina tobacco users. That's 0.4% of North Carolina's smokers. Ideally, a Quitline should ultimately, if it's promoted and funded, should reach 2% of smokers per year. We set a goal for them in the next 2 years of getting 1% of the smokers per year. Got a long way to go. You've started to see ads, I'm sure, on TV, because they just started a promotional campaign in the last month. If you look at how patients say they hear about the Quitline, the number one thing is TV commercials, and that's why they're going after the TV. Among all patients, though, number two is health professional. So that's why I'm spending some time today to encourage you to be aware of the Quitline so that you can tell your patients about it. And even if you're counseling them and don't have a whole lot of time, this is part of it. So even if you're giving them a prescription and you've only given them a brief counseling, you can refer them, and again, they will get free proactive counseling most days of the week. The Fax Referral Program is for those who want to quit in the next 30 days. You can download a form. We're going to put it on our website. Actually, it's probably already on our website, ndp.unc.edu, and you can immediately institute a fax referral, and then people will call them. This is a copy of the form here. Our program is started up just really about 4 months ago, and it's located in family medicine. And it came about in conjunction also with the new UNC policy on tobacco use. This was the tobacco-free zone, and you notice it based upon where there are signs. If there's a sign that says it's a zone, it's a zone. And it covers, and for those of you who have been walking around here, you know, how many people in this audience think that there's a significant reduction in secondhand smoke exposure walking around this hospital campus? I mean, it should be virtually every one of you. And you saw, the worst part was walking over to the cancer center and seeing the patients smoking, and the sign saying Cancer Center right next to where the smoking bench was there. And then all the smoke-free signs and seeing patients smoke under it when, of course, it was raining there. So we're doing a compliance study, but dramatic decreases, actually very, very few problems. And the reality is over 80% of North Carolina hospitals have now adopted this. To give you some idea of how significant in a leadership role in North Carolina that is, nationally it's 5% of hospitals. California hasn't even begun to approach this. We're presenting stuff at the National Tobacco Meeting next week in conjunction with Prevention Partners in North Carolina. This is one of the great successes. We're preparing an MMW article about this. Interesting reasons for it, but incredibly successful. Our program is actually about all kinds of ways that we can interact across the health system, across the community, with patients, inpatient, outpatient, providers, and providing comprehensive support for this issue. For employees, I mentioned our group classes there. We've actually done some research on UNC healthcare employees. We did a survey of all employees 2-3 months ago. We got 2,000 employees responding just to see do they agree with the policy. And over 70% agreed or strongly agreed with this new policy there, including much higher among non-smokers. Even among the current smokers, about 25% were not opposed to it there. If you look at among our employees, how many are smokers of those that responded, we have about 12% of healthcare employees that are smokers. That's probably somewhere maybe a little bit more than that. Interesting, 3% said they quit within the 6 months of doing this survey, meaning that they quit for a large part because of this new policy coming about. This is much higher than what we normally see, 25% of smokers within a healthcare system quitting. So we know this policy is having a large impact actually on cessation. It's driving people to quit, and that's actually one of the things. In terms of inpatients here, we again are working to change the processes. We are available for consults in special cases through a pager, or through an email, through different ways of getting in touch with us. We're tracking the utilization of medications in our system. This slide just shows the great increase over time at different points in times, and to the far right of each column shows the increase since the policy went into effect. So the great increase in the utilization of nicotine patches and nicotine lozenges and the total nicotine replacement orders. Varenicline was not really on formulary and is not there for an inpatient use, and this is for hospital patients, so that's why you don't see its utilization here. This is the nicotine-dependent order set that I mentioned here, and again, you just click on nicotine replacement, and this is what opens up a whole list of different things that you can check off. And again, with the hospital leadership, we were able to get this in place, I think, in really quite record time to help there. In terms of the outpatient counseling, I mentioned the different clinics there and the documentation overall of the increase of the counseling assessment rate from 56 to 65%, and the 25% that weren't still there. And we can see, again, internal medicine and family medicine doing really quite well, some real problems in gynecology and psychiatry in terms of that study visit there. And then the use of the current smoker vital sign, internal medicine, again, was doing very well to start with, close to 90%. I think this is really excellent, and I think shows some leadership of the people who've been working on this in medicine there for that. Again, if you need to call us, 966-0211, Carol Ripley Moffitt should raise her hand, is our program manager, and can be gotten by email, website, phone call, or pager there, and allows us to intervene at all different places in the system there. The last thing, and then I'll take questions, has to do with the policy advocacy here that we spend a lot of our time, is we do a lot of work to promote policies that will reduce tobacco use. And whether, again, this is reducing the promotion or reducing the access or eliminating secondhand smoke, we have a large secondhand smoke evaluation and research program there. We've been working a long time in promoting tobacco-free school policies. So now 80% of the hospitals around the state are now 100% tobacco-free. We've been working for a long time to get school districts. So now over 75, it's actually 80% of all school districts, elementary, publics, and high school, are tobacco-free on those campuses. It didn't used to be that way 3 or 4 years. And legislation passed in this last General Assembly that requires all schools to be this by the end of, I think it's August of next year. And this just shows the remaining ones that haven't done it yet that will be 100% tobacco-free there. You see commercials on TV, a lot of commercials. We've done research that shows that what will work in North Carolina and be politically acceptable are real stories about North Carolinians that really make you and make kids take a step back and say, So we call them evoking negative emotional tone. And that's what you're seeing in here, because the things that you see by the Legacy Foundation, the truth commercials that really go after the tobacco industry, would not be politically acceptable in this state, and they wouldn't get paid for, they wouldn't get run. Currently, there's $5 million media campaign running in North Carolina a year. It's phenomenal. It's a huge success story. We're doing 8 papers at the National Tobacco Conference next week, in part telling about a lot of the stories of things that are happening in the state that are remarkable. This was the first time ever a media campaign to promote tobacco-free schools, first one in the country that aired in North Carolina this past summer. It's not all success. A bill to eliminate tobacco smoke in almost all restaurants and all public places failed by 3 votes in the North Carolina House of Representatives this summer. How many of you called your representative when this was all in the paper and said, this is good, as a physician, I want you to do it? The chances are it'd be less than 1% of us did that. So there's opportunities. North Carolina can actually still, this will be a huge thing for us and our patients there. If you look at where smoke is still happening, arenas and airports, there's not much. Airports, there's a little bit actually. This is a survey, we did a statewide survey, but where you see where there's still a lot of that with no limits, or the convenience stores you go into, bowling alleys, other areas there, but yet they know about the science. These are the managers and owners of these facilities. We interviewed 300 of them around the state. They know this is bad, but they're scared to do it still. It's North Carolina. They say if we're going to do it, it'll be legislation there. And we know if we do it, it helps people. This is based on California data and JAMA, and New York data, that people get better when they're not around the cigarette smoke. It's not really rocket science there. We do evaluate the media campaigns, the Quitline. There's a large teen program. It's about $18 million a year North Carolina is putting into it, as well as a college program. 8 colleges around the state have adopted 100% tobacco-free campuses. So again, when you see Carolina making significant progress, this is happening around the state. And again, North Carolina will be the leader nationally, if they're not already, in terms of where they're heading in tobacco-free colleges. So this is a whirlwind. I think we have about 5 minutes for questions. But I really wanted to give you a sense that, things are changing. This is a different environment than it was in the past. The opportunities are there. There are new pharmacotherapies. There are new resources. We have Quitlines. We have fax referrals. We have advocates around the state. There are things that one can do at the community level. There's a lot of things that one can do at the clinical level to really make an impact. And I would hope if I came back 10 years from now, maybe I'm talking about a whole different topic. So let me stop and see if there's some questions. Yes?
Very good. And I just want to let everybody know that prescriptions for nicotine replacement and the other smoking cessation aids will be available to university employees through the University Occupation Employee Health Service and ACC. We actually have them available now. And although this isn't official, I've been told that the Chancellor's announcement for the smoking ban on all buildings in 100 feet will come out next week, and it will be January 1 implementation. So the whole university will be smoke-free as of January.
Thank you, Brian. And there's actually, again, if you have an opportunity just to scan the environment, with the exception of the football game, which I think that people ignored the bans, at least in our parking lot they did, there's been a lot of progress. I believe either now or coming up, for instance, you won't have smoking in Kenan Stadium. That's been a perennial problem. If you go in the concourses and you go to the football games, you're really exposed to secondhand smoke quite a bit, and they've already started looking to it. Yes?
Can you talk a little bit about the cost of nicotine replacement therapy and the cost of
Varenicline. Yeah, actually I had a slide, but it's way too small to see, so I took it out. That compares the cost of the different pharmacotherapies. They're actually not all that dissimilar. They range from $3 to $6 a day. A pack of cigarettes today is about $4. If they pass the S-chip legislation today that is in Congress to make insurance for about another 40% of kids around the country who don't have insurance, they're paying for that with the increase of the cigarette excise tax federally by 75 cents. And so cigarettes will be close to $5 a pack. So I tend to think of it in that realm. I think Varenicline is probably on the right there. And so, but the reality is for Pfizer, Varenicline is the fastest growing drug they've ever had, faster than Viagra. 3 million Americans, and this is before they did any direct-to-consumer advertising, and the reality is most of that was being driven by patients going to their providers asking for the drug rather than the providers recommending it to their patients, really, which tells you something about its effectiveness, unlike the patches, which I've been underwhelmed by their effectiveness in primary care. Dr. Adler.
Yeah, and let me try to raise an issue, but before I do, since we're talking about a sacred cow, let me make it clear that I applaud everything you're doing, and I think that should be regulated by the FDA, and there's no reason.
I'm not sure it should be regulated by the FDA, but that's a different question.
But there are some interesting observations that can make it possible that we're missing a little bit of the forest for the trees, and that relates to transnational attributable mortality. I first realized this teaching in Japan when you see most of the havoc of tobacco abuse in much, much older people. And in fact, there is enormous transnational differences in the attributable mortality. It's not a safe used substance any place, but you live much longer if you're Japanese smoking in Tokyo than if you're Japanese smoking in San Francisco. And when you do the transnational epidemiology, you learn that tobacco abuse has covariants like socioeconomic status in our country, education, a number of these things. And we seem to be willing to spend a fortune looking at some of the elements of the station in life without looking at why these unfortunate people are drawn to tobacco with all of its recidivism issues. You didn't talk about recidivism, you just talked about expense here. I wonder if we might talk about distribution of wealth and resource, not just simply looking at one symptom of maldistribution.
So the question really is a broad question for which we could go into an entire course to discuss the distribution of tobacco as it relates to transnational and inequality, and it's in the variation in risk based upon location as well. So a lot of dimensions there. The one thing about transnational it's important to understand is that you're right at the level, and maybe you didn't ask it specifically, but the tobacco use transnationally is a far greater problem than it is here. And the reality is anything that we do in North Carolina has a minuscule impact on what happens transnationally. It's an important and great issue. The World Conference, there's a World Tobacco Convention treaty that's been signed by over 2/3 of the countries in the world. The U.S. was one of the last ones actually to come on board to look at this and to figure those elements out there. A different kind of question. The other element is that tobacco use is the #1 cause of preventable mortality in every country, just about at a certain time when they develop. So even in Japan.
That poverty may be the #1 cause of preventable mortality in every country, every state, and it maldistributes across our country. It's called the Robin Hood effect, and tobacco abuse is just one symptom of it.
Yeah, we could have that discussion, and we would probably have to eventually agree to disagree. In most developed countries, in the developing countries, tobacco will overtake those things by all things, and it'll be 10 million a year in deaths. But again, I'm not saying it's an either or because they're both there. And I applaud any efforts that you and other physicians do to really decrease and make the world a more equitable place. The industry takes advantage of those things and specifically targets African Americans, pregnant, youth, those that have.
Including Pfizer.
Yeah. Last question.
Well, more of a comment than a question in public health policy standpoint. It seems sort of ill-conceived to create a perverse incentive whereby the more successful we are in getting people to quit smoking, the less money is available for children's health for those children who don't have insurance. And I would encourage those who have any say in that matter to not use tobacco excise taxes to fund health care.
Well, actually, I think it's the other way around. I think it's 180 degrees in the other direction. So the question is, how does the excise tax on tobacco in terms of the insurance rates? First off, tobacco is a mostly inelastic product people in terms of its addiction, so a lot of people continue. But the excise tax will disproportionately cause those who have less income and youth to quit. So there'll be dramatic reductions in those who are actually more vulnerable from that excise tax in addition to the insurance. So from a public health viewpoint, it's actually a tremendously good thing, and really no public health people that I'm aware of in the country are aware of it, are against it on the grounds of its impact on public health.
Adam, thank you.
Thank you very much. I appreciate it.